So I'm here to talk to you about telehealth and telestroke, and the first thing I want to do is thank the Foundation for inviting me here and asking me to present on behalf of Sechelt Hospital. I'd also like to clarify I am not a doctor. As you heard in the intro, I am a nurse, and I am in no way, in any means, a stroke expert either. What I'm here to present to you is the services that we can offer at the hospital, both for telestroke specifically and for rehab services. As I said, I am a nurse. I have a long history of working in hospitals. I'm not going to tell you how long, because some mysteries need to be kept mysteries. But over the past few years, I've had the privilege of being the manager at Sechelt Hospital Acute Services, and this includes the emergency department, which is part of our telestroke. So face, arm, speech time. Hopefully you've all seen this before, and I know that on some of the display tables there was magnets and things that you could have that have this. And if you take nothing else from what I'm telling you tonight, it's this. This is critical. So this is how you recognize the symptoms that you may be having a stroke, or someone that you know or love is possibly having a stroke. So face droop, raising both arms, possibly can't raise one arm when trying, speech, slurred speech or jumbled speech, and time. Time is of an essence to get care as soon as possible, and I'll explain why as I go further through it. But definitely, if nothing else, as I said, this is the piece I want you to take away. There's a couple of different types of strokes, but first of all, I want to briefly mention TIAs, or transient ischemic attacks, because this is like a warning sign of possible stroke to come. A transient ischemic attack, and I'm going to quote, there's 3 different quotes I'm going to hear of explaining strokes, and I've taken them directly from HealthLink BC. Is a transient ischemic attack happens when blood flow to the part of the brain is stopped for a short time. It's also called a mini stroke because the symptoms are the same as a stroke, but they don't last as long or cause lasting damage. A TIA is a warning that you may have a stroke in the future, and early treatment can help prevent a stroke. So early treatment may be a follow-up with your physician, looking at your diet, your exercise, your blood pressure, looking at your lifestyle, things that you can do to put into place to prevent possibly a stroke from happening in the future. It's like your early warning. And then the 2 types of stroke. So there's an ischemic stroke. So an ischemic stroke happens when a blood clot blocks the blood vessel in the brain. The clot may be formed in the vessel, or it could have traveled there from somewhere else. About 8 out of 10 strokes are ischemic strokes, so highly likely that if you're having a stroke, is most likely an ischemic stroke, because they are the most common. The second time is a hemorrhagic stroke. This develops when an artery in the brain leaks or bursts. It could be caused by trauma, or it could be caused a spontaneous break or leak. It creates pressure in the brain, so the arteries, the vessels around it, not only can't get the blood flow to them, it also creates a pressure buildup of that bleed in the brain. This is less common, but unfortunately is probably the most devastating type of stroke to have. Okay. So just some statistics that I got from the Canadian Heart and Stroke. These are from 2017, so they aren't the most up-to-date, but they are just kind of gives you an idea of the prevalence of stroke in our society. So every year, approximately 62,000 people with stroke or transient ischemic attacks are treated in Canadian hospitals. Beyond that, there's a lot of people that have symptoms that are milder, that don't seek treatment, that are not recognized. Stroke and other cerebral vascular diseases are the 3rd leading cause of death in Canada, and stroke is the leading cause of adult disability. The annual cost of stroke is approximately $3.6 billion, taking into account healthcare and lost economic output. But the human cost of stroke is immeasurable. What it does to an individual and your family, you can't put a price on. Although there are many proven interventions for stroke, and there are different types of treatments and rehab, they're not all widely consistent, depending on where you live, your community, and what's available. So this is what takes us to the next piece, which is telestroke. So telestroke, and how does it work? So telestroke here in Sechelt came about with the collaboration of Sechelt Hospital, Vancouver General Hospital as the stroke specialty center, BC ambulance service, including the Air Medevac, and a regional stroke collaborative. And it was a group of people who all came together saying, how can we provide the best stroke care to our rural areas, knowing that we're not going to have those specialists in those areas? And what can we do? So there's multiple factors in this. It's the time, getting people to the hospital and recognizing it. It's also the time after treatment, getting them to the care that they need, if they need at a higher level of care. But the big part is getting that specialist to have that assessment. So that's where the telehealth and telestroke come in. And I'm going to use those terms slightly interchangeably. So the Sechelt Hospital Foundation also assisted with a donation of funds to purchase the telehealth video equipment, which is crucial to the success of the service. These units cost in a range of $37,000 each. By bringing telestroke to Sechelt, we're bridging that gap between the rural sites without the specialty service, such as a stroke specialist, and allowing the patient to have the same level of care as those in the larger cities. The emergency room team, along with a specialist in Vancouver General Hospital, do simulation exercises on a regular basis, using the equipment and running through scenarios so that when they need to use the real stuff in real life, they're ready. So I have a video clip. I actually have two video clips, but one of them I want to show you first. Well, I'll show you this one first. So this is one of the neurologists who is on the video telehealth monitor, and he wants to introduce himself to you.
Hi, I'm Sam Yep. I'm one of the stroke neurologists over at Vancouver General Hospital. We provide a stroke service or telestroke service for Sechelt. And hopefully you don't get to see me here, but if you do, you actually get to see about 7 of the stroke neurologists over at Vancouver General Hospital. We try to provide hyperacute stroke care for people living in Sechelt
So I apologize a little bit for the sound quality of that. It was filmed by one of the team members on her iPhone. And so it doesn't come across just as nicely as we like. The second video is actually a clip from one of the simulation exercises that we recently ran. So you'll see Dr. Yi, Ruby Yu, I don't know if any of you are familiar with her. She's the doctor in the scenario who's treating the stroke patient. And there's a couple of nurses just in the background. But the patient on the stretcher is actually another one of our physicians.
A CT head, which doesn't show any hemorrhage. And right now he's still weak on the right side. His right side, he has a right facial droop, and he's not answering any of my questions. Sorry, I can't bring you any closer to him right now. So I was just about to do the stroke scale.
Okay.
But is there anything else you want to know right now?
Is he on any medication?
Yeah, he's on he has atrial fibrillation and hypertension and diabetes. He's on metoprolol and aspirin. I think, and hydrochlorothiazide.
And what's his blood pressure?
His blood pressure is now 165/80. It was initially 220/110, and I gave him 10 of labetalol.
Oh, okay. So it's come down and it's staying down.
So far, this is the first measurement we gave it just a few minutes ago.
All right. I assume that I have an imaging to look at
Yeah.
while you do the exam.
It's
okay, go for
normal CT head. Okay, so do you want me to go ahead and do the stroke scale?
Sure.
Okay.
Yeah.
All right, so Justin, can you look at me? Okay, can you tell me your name? All right, can you see okay?
Yeah.
Dr. Yip? Okay, and just look at my finger and follow it with your eyes. And I'm seeing normal extraocular movement. Okay, I guess visual, I can't really tell. Facial palsy, there is a right facial droop there. So I would say probably complete paralysis. Can you smile for me? Yeah. I would say complete paralysis on the right side. Can you lift both arms up for me? Okay, and there's only a twitch in the right arm right now. And can you try lifting this leg up for me again? And again, it's just a twitch in the right leg. All right. And 3. Can you feel me touching here? Yeah, in here? Can you feel that? Yes? Okay. Can you just say no? Can you say no for me so I know what your no is? That's no? Okay. Can you say yes? Yes? Okay.
It's
That's difficult.
indistinguishable
Okay.
between yes and no.
All right. So I can't really test sensory. And I would say he is aphasic and dysarthric. And I don't think we can really test extinction from there.
Okay,
Yeah.
so he's NIH, pretty large NIH, probably up in the 60s or whatever, 20s.
Right.
Okay. And the blood pressure is good?
It is good. Should we
165 over 80.
Coagulation,
Want me to-
and his blood
It's the
work is
same.
cooking, I
It's the
guess.
same.
Blood work is
There's no
cooking.
history of bleeding issues. There's no recent surgery.
Nope.
No recent surgery.
No history of bleeding.
So we're going to stop it there. It goes on, because it was a simulation, they do a lot of debriefing afterwards and talking, what could we have done differently, what did we really do really well, making sure the connection is good. But it gives you a really good idea of the conversation between the emergency doctor, the team, and the specialist who is giving real-time advice, real-time questions. So I'm going to go through just sort of what would happen in the scenario if you were coming into the hospital, having experienced symptoms of a stroke, and kind of some of the things you might expect based on what you've seen. So a patient presents to the emergency department with signs of a stroke. If they're presenting via an ambulance, the paramedics will have called ahead of time to the hospital, and the team will be there preparing for their arrival and often will meet them right at the door. Initial assessments done by the emergency physician. A quick history is taken, vital signs are taken, followed up by an urgent CT scan. Sorry? Oh, sorry, I thought I asked. There was a question. Using the telehealth video equipment, the team at Sechelt Hospital can connect in real time with the neurologist. The technology allows the neurologist to speak to the patient, examine the patient, and also view the results of the CT scan. So the CT that's done in Sechelt, the neurologist actually can see right away, and they can make a decision based on that scan about what the course of treatment, the best course of treatment would be. They don't have to wait for it to be sent. They don't have to wait for anyone to read it. They actually can read it in real time. So the consultation might also be via phone. So I don't want people, if you've ever had a loved one or someone come in with a stroke and go, well, they didn't bring in this video equipment, they didn't do this. It doesn't mean that the consultation didn't happen. Just sometimes, depending on what's happening with the consultant at VGH, their ability, they're on call 24/7, so they're not always available for the telehealth, but they are always available for a phone consult. So it may not be the full telehealth, but they can definitely do it for a phone consult. The other piece of that is they can read that consult, and if they look at that and they know just definitively based on that CT scan, they don't need to ask the other questions. They know what the course of treatment is going to be. They can make that decision and express that to the emergency physician right away. A CT scan is done before a decision regarding the type of treatment, and that's imperative. And the reason that is they have to work out the type of stroke that has occurred and differentiate between an ischemic stroke and the hemorrhagic stroke. And if we recall, the difference is one is a clot and one is a bleed. Sometimes the course of treatment is TPA, otherwise known as alteplase. But this is only the course of treatment for a blood clot. And the reason is this is kind of a clot buster. It's a blood thinner. And you definitely would not give this if somebody's already having a bleed, because it will only make matters worse. It's not going to improve things. So not everybody gets TPA. And not everybody that has a stroke caused by a clot gets TPA. There's lots of factors before we want to give that we have to consider. Some of those things would be a history of other brain bleeds, recent head injury within the last 3 months, other bleeding disorders. If you have maybe a peptic ulcer that's bleeding, you wouldn't want to give something that's also going to thin the blood because you're just going to exacerbate other issues. Or anticoagulant use within 48 hours. So people that are on warfarin or other blood thinners. Aspirin is also considered, so someone who's taking regular aspirin. All these things are factored in. It doesn't mean that they definitely won't give TPA, but they all have to be considered. So again, I've heard people say, well, I didn't get that treatment, or someone I know didn't get that treatment. But the best course of action is decided by the clinical specialist, and there's a reason why they choose not to or not give it. Time is also important. The benefits of the medication lessen the longer the symptoms have gone on. So ideally, it's given within 3 to 4 hours of onset of symptoms. Doesn't mean that if it's been longer than that, you won't get that treatment. It just means that all other factors have to be considered because TPA may not be as effective, and there might be other treatments that they choose to use instead. So this is where we go back to fast and time. Soon as you recognize symptoms, getting to the hospital, and if you find out that you have an ischemic stroke, giving the TPA is going to have the best results if that's what's right for you. After TPA has been given, a patient may be transferred to Vancouver for continued stroke care and ongoing assessment from the neurologist. But even if the decision isn't to administer TPA, the patient may be transferred for more specialized care anyways. Sometimes people go for an embolectomy, which is a surgical way of removing a clot. Some people go for a carotid artery bypass because the issue may that they have a blockage in the carotid artery that needs to be cleared to provide blood flow. Depends on what's going on for each individual, the course of treatment. It's important to note that TPA doesn't work for all patients, even if it's given within the time frame specified. Some people make a full recovery, and others have lasting symptoms even after that. And there's a lot to think about when kind of talking about what kind of treatment that you want to have or what's the best treatment. I just want to touch on the TIAs for a second here. I don't want to forget that. So patients that are diagnosed with TIA coming to the hospital, TIA symptoms resolve on their own. That's part of the definition of them. So these people will often be discharged home to be followed up with their family doctors, but they may also be referred to the high-risk TIA stroke clinic at VGH. This clinic is a clinic with specialists that look at people that have had TIAs, whether recurring or one-off, and they work with those people to look at the risk factors, why they might be having TIAs, and what they can do to correct that course of, leading to a stroke or not. So people that have been coming to a hospital and showing symptoms of a stroke that are resolved on their own don't often get admitted. But there is always a consult with a neurologist or some specialist, and there is always follow-up care offered. Just want to let you know that from May, which is when we started using telestroke, to November, which is when I last had specific data, there were 18 incidents where the telestroke system was used. 6 of these people received TAPA. Most did very well. There's also numerous other occasions when the ER physician just connected with a specialist for consults only without going through the whole process. So just having that resource has been huge for our team. So you've had the stroke, you've been in hospital, you recovered, then what? So then we start looking at the rehabilitation piece of it. So there's different factors to rehabilitation. Some patients don't get sent to Vancouver, some stay in Sechelt, and then others come back to us once they've reached a certain level of care in Vancouver and they come back to our hospital. They will receive treatment within the hospital as patients there for our in-house rehab team, and we have physiotherapists, we have rehab assistants, we have occupational therapists, and they work to set up goals and a plan for recovery. And they also work to set up a discharge plan. What can we do? What do we need to do to make people feel that they can go home safely? This might follow up to them being followed as outpatients in the hospital, with people able to come in and see the same people that they've been working with on that team as an outpatient. And some of you might be part of different groups that come and visit for various other things, our outpatient rehab department. For some patients, the team will discuss having them spend some time at Holy Family or GF Strong. Holy Family and GF Strong are both centers in Vancouver that offer intensive rehab-focused care. Each of these centers has very strict criteria for the patient that can be accepted, and most being in regards to their goals that the patient has set and their ability to work towards these goals. Rehabilitation is exhausting. Any of you who've gone through any form of rehabilitation, whether it's from hip surgery or knee surgery or anything else, it's exhausting. But the biggest part of this is mindset. People have to have the right mindset. So when we're looking at referring people to Holy Family or GF Strong, it's just not the rehab goals, it's the patient's mindset. Are they able to meet these goals? Are they going to be able to work through these goals? And are they going to be able to meet the requirements, the exhausting requirements of intensive rehab? We also have TIDES program. So the TIDES program, you can go on the next slide. TIDES program, you probably met some of the members out in the lobby when you first came in. TIDES is a rural remote rehabilitation program for people once they have been discharged, and its specific focus is rehabilitation services for individuals having recently had an acute neurological injury, such as a stroke. TIDES was made up of a physiotherapist, an occupational therapist, speech-language pathologist, and a rehab assistant. And they see clients in Sechelt, Powell River, Squamish, Pemberton, Whistler, Bella Bella, and Bella Coola. Small team, huge geography. They do this by using telehealth. So the same system as we allow the specialty service for the stroke specialist, they use that same type of system. They have very strict criteria as well, which I'll go through in a minute, of who can be seen. But they're making great strides at seeing people in their own communities so that they don't have to travel. And so it's really trying to bring the services in the rural remote communities on par with what's in the urban cities again. And that's the kind of the goal that we're looking for there. So patients who have had recent acute neurological injury, such as a stroke, patients that have been rehabbing in their hospital site, they're medically stable, and now they're ready to go home, but they still need to continue with their rehab. They still have attainable goals. This can be with the occupational therapist, the physiotherapist, the speech-language pathologist, a combination of all three. They do an assessment, they do an interview. It could be, they could see all three of those specialties or just one of them. The rehab assistant is trained to follow up any plans that are set up by the specialist, the therapist, and follow that up with the client. These people must live in a remote and rural community. They have to have specific, realistic rehab goals. They have to demonstrate rehab potential and be motivated and able to learn. And they have to be able to travel to the main hospital in their area to attend appointments. We, at this time, are not able to see patients in their own homes. And they have to be willing to use the telehealth as part of their treatment plan. So what might happen is if we had a client in, say, Pemberton, the physiotherapist who's based in Sechelt, and the whole team is based in Sechelt, apart from rehab assistants that are in each area, will go there initially to do an in-person meet and greet and figure out with that person what their goals are and what their plan needs to be. They will then work with the rehab assistant locally to follow that plan, and they will do regular follow-up through telehealth, where the rehab assistant with the client will do the plan, and the physiotherapist based here will watch and say, how's it going, what are we doing, and do the check-in. So it allows a small team to see a huge geography of clients and really gets those services to people in their own areas. So the next piece I just want to touch on very briefly is what matters most to me, advance directives and representation agreements. And the reason I put this in there, and I debated about doing it, but I decided I would anyways, is this is really important for people that are coming into hospital, particularly having had a stroke or something of similar nature, who are not able to speak for themselves. In that crisis, in that moment, you want to make sure that your wishes are known and followed. And if you're not able to speak for yourself, you want to be sure that you have somebody there who can speak for you. So Vancouver Coastal Health has a form called What Matters Most to Me, and it can be completed, and you can bring it with you to see your doctor. You can bring it with you if you come into hospital, anytime you're accessing healthcare. And it allows you to have that discussion with your family and your caregivers prior to needing treatment so that your wishes are known. And there's some simple questions that you just answer. And it forms the basis if you wanted to do a more in-depth advanced care directive. And advanced care directives, I'm not going to go into detail. We can have a whole MedTalks on those. But at the end of this night, I have some copies of What Matters to Me form for anybody who wishes to take one with them. I also have a sheet with some links, not just to good websites, like the government of BC has the best website on advanced care directives, believe it or not. But it has the links to those sites where you can go find out more information. It has also the links to the Heart and Stroke Foundation, HealthLink BC, and a few other ones that I thought were very useful and just wanted to pass on to you. As I said, in time of a crisis, you want to have your wishes known. And it's never, ever too early to sit down with those closest to you and have these discussions. They're hard conversations. but they're very important conversations. And as a healthcare team member, often I will sit with families who have loved ones that are having trauma or something's going on, and I'll ask them, what are the wishes? What did they want? What are they hoping for? And sometimes people know exactly what it is because they've had those conversations and they're able to speak very confidently about that. And others are just devastated and they're like, I don't know what they'd want. I really don't. So even just starting the conversation is a good point. So finally, I want to say thank you. Thank you for listening. Thank you for coming tonight. Thank you to the foundation.